Hello, everyone. I'm Tony Monaco, the president of Tufts University, and it's my pleasure to have this webinar on COVID-19 student and community support. Firstly, let me thank our colleagues at MEMA, the Department of Education, and DPH for helping us put this together and supporting us. In addition, there's a broad audience on this webinar today. We have members from higher education, nonprofit organizations, government officials, and those in the healthcare sector. Welcome to all of you. We also have some people from the media present as well. Firstly, let me mention our fellow panelists. Professor Moon Duchin, a mathematician from Tufts University, who will have a few slides later. Our clinical colleagues, Dr. Mike Apkin, President and CEO of Tufts Medical Center, as well as Dr. Asad Sayah, CEO of Cambridge Health Alliance. From Tufts, we have Barb Stein, who's the VP for Operations, and Captain Wes Hester from the US Coast Guard and now at the Fletcher School at our university. With that, let's get into the presentation. The next slide, please. Our goal here is to leverage college and university resources to lower the infection and mortality rate of COVID-19. The context of this is the overwhelming demand, and starting now and into the next couple of weeks and months, on hospitals and the healthcare system. We've all seen the scenes from Italy where they've had to use makeshift tents, hallways, and parking lots during the surge. I don't think we're there yet, but we do need to focus on how to help our hospitals maintain their beds for critical care, as well as meet the needs of first responders and healthcare workers. And I know the latter category is the area that many of you have been asked to help. Next slide, please. So how can universities and colleges help? Well, one idea we've had is the surplus residential capacity in our campus facilities since dedensification in March could be used as capacity to reduce strain on hospitals. This webinar will focus on two levels. One, what can we do as individual institutions partnering with our cities and our healthcare providers? And I'll try to provide some examples from Tufts as a case study. Secondly, there is a data-based assessment of needs and opportunities, which should allow us to optimize connecting hospitals with their local college or university. Professor Moon Duchin from our mathematics department will be sharing that tool on how to optimize locations. Next slide. Some other uses that you might be asked, we certainly have is as outdoor testing sites, particularly housing high risk or exposed workers to keep them away from families and vulnerable members. There's first responders, healthcare personnel, as well as your own university staff, including police officers. And we had an example of that as on our own campus in addition to students. Working with Cambridge Health Alliance, we'll show some examples of how we plan to use one of our dorms for COVID positive recovering patients in a skilled nurses unit. And then there's also the possibility of non-COVID positive patients receiving ambulatory care in a separate location. Next slide. The partners and requirements of this, of course, you have to think about your local cities. You have to think about your local and regional healthcare providers and engaging the members of your own community. The requirements are you need leadership commitment from this at the top. You need to get your senior team involved and on advocating for this. It does need cross-functional support from many different aspects of your teams, including legal as well as operations. One of the first things we did and we would recommend is doing that inventory of all your campus resources, and then also considering how, if you're going to enter into agreements with healthcare providers or your cities, having clear operating arrangements and plans on how to return your facilities back to university use at the end of this time. Our partnerships have been with our cities of Medford and Somerville, Tufts Medical Center and Cambridge Health Alliance as two healthcare providers, and we drew heavily on military logistics and planning expertise at our Fletcher School of Law and Diplomacy. And really, one of the reasons we were able to get so far ahead on this is because of that expertise. And one of the goals for today is to help you what we've learned through working with these fellows so that we can bring others up to speed if they're interested. Next slide. The principal uses does require some thinking about how you're going to liaise and vet all these requests. Obviously, you have your city and your clinical partners, and they are getting many requests, but you do need to have someone in your operations, usually your community relations office, which is helping to field these. And we would suggest that you push the random requests back onto your partners because they have better mechanisms of managing those situations. We certainly have tried to appropriately designate different zones of our campus, whether it's an up and down campus or different ways of thinking about those zones to house different populations. Next slide. We want to make sure that if it's not your own students or staff, and these are areas that are going to be provided for hospital or medical personnel, that your partner organizations, to the greatest extent possible, should really provide the services and help to manage those populations. It's also important to have transparent communications with your community to make sure they understand what your goals are, how you're managing it, and that you're keeping your academic mission as well as their health and safety at top of mind. We also, of course, want to share our experience with our peers. We've done that on one-offs, and this is an opportunity to do that on a larger scale. Next slide. I mentioned testing locations. We had a look at this. We are not asked yet to provide a testing location, but obviously parking lots, flow through areas that are on one-way systems that are close to major streets. You and your operations team working with your cities or healthcare provider would be able to look at those different options. This is just an example from our campus, and we've circled 2 locations on our upper campus and one down by our athletic facility that might work. Obviously, that's something you might want to consider, and we're happy to help you with that. Next slide. I believe most of the requests people are getting at this time, however, is on looking at housing requests. You have your own students, faculty, and staff. I mentioned that your police force may have one of the first people on campus exposed and needing isolation, and that certainly was our case. We have high-risk exposed workers who want to remain separated from their families. We have first responders from our cities, towns, and communities, and healthcare personnel from our hospitals and healthcare providers. And I mentioned the 2 types of hospital activities, either COVID positive recovering patients in communal housing as a special nurses unit, or ambulatory care patients that are not COVID positive. Next slide. You need to think about the logistics carefully. We looked at isolatable rooms versus rooms that are more of a standard corridor-like dormitory room, community versus private bathrooms, buildings that have stairs versus elevators. Our general conclusion was that first responders, healthcare personnel, and your own university staff are better housed in smaller groups, suites, buildings that have separate entryways with no horizontal communication across different levels, so that if you want to separate healthy workers from those that are exposed and quarantining, perhaps waiting for testing, versus those that are COVID positive and isolating, you need 3 separate units for each of your situations. Secondly, if you're thinking about COVID positive recovering patients or ambulatory care, there your standard dorm corridor with multiple rooms staffed by a nurses unit might be your best option. And I'll allow later my clinical colleagues to expand on that if any of you are interested. Next slide. Here on our same picture of our campus, you can see our lower campus down at the bottom. That's where we're housing our current students and have isolation units available to them. And then we're segregating our upper campus. The red is where we're possibly housing COVID positive or ambulatory care patients in a standard type dormitory that has elevators. And then the one circled in green are wood framed houses or apartment style separate entryway suites that we'll be using to house first responders and medical personnel. You can see that they're very close to the periphery of the campus. They have access via streets so that someone doesn't have to come far internal to the campus to access those points. Next slide, please. Some of the support considerations, and I think this is probably where a lot of your questions might lie. Again, you need to consider these things, but in our case, it was much easier to have our healthcare provider and partner provide many of these things. For example, housekeeping and sanitation for the lodging and spaces that they're managing. That includes laundry, trash removal, and deep cleaning. Dining services, many of the hospital partners have patients that require special dining requirements, and they would prefer to do that. Again, you can have conversations if you have spare kitchen facilities or the ability to deliver food working with your partners. Obviously, IT network availability, storage space, and other large spaces like gyms or field houses that might be required. And I know some of you have even been asked for spaces like ice hockey rinks if there's a local surge on morgue space. Next slide. Some other things, as I mentioned, whether you have accessibility in elevators, that's especially needed for any kind of patients that are needing access to upper floors. With your partners, you can look at the clinical suitability related to federal and state requirements. You have to think about your public safety support. Again, we would think that it would be better for the healthcare provider to provide their own security at the building site, and then your public safety individuals sort of supporting from the periphery. There's all the licensing, medical and legal issues, as well as liability issues. Our general counsel's office has been running a separate webinar on that with general counsels across colleges and universities, and we're very happy to provide that support as well. Next slide. Lastly, as many of you are doing, there's areas that you can support around medical supplies. We've been doing mask repair and any other kind of community service. We've been leveraging our support networks, parents donating PPE, or alumni getting involved, and then trying to get your research and innovative thinkers in higher education working on some of the urgent issues that have come up. Now it's a pleasure to introduce Moon Duchin, one of our professors, who would like to walk us through one tool that she's developed that might help state officials and universities and hospitals understand how to optimize partnerships in this unprecedented time. So next slide, and take it away, Moon.
Okay, great. Thanks so much, Tony. So I'm Moon Duchin, and I'm a math professor here at Tufts. And I also run a lab called MGGG Redistricting Lab that looks at redistricting and gerrymandering. So that means we have math modeling expertise, we have computation expertise, but also geography and kind of geospatial data. So that means that we were able to take some of that expertise and leverage it to do some quick modeling to match from hospitals to campuses. So this is sort of a classic math modeling setup. We call it a network flow or an optimal transport problem. You have source nodes. In this case, you have hospitals that need to send different kinds of populations of people out. And then you have sink nodes, which are the college and university campuses. And what we want to do is we want to minimize travel time and come up with a good match. And the idea there was to take the three separate populations that you've heard about, which are medical personnel and first responders, the non-COVID ambulatory patients, and then COVID positive recovering patients, and think about giving a matching to dorm beds. What makes this so fundamental as a partial solution to the problems that we're facing and will continue to face in this crisis is just the sheer size of dorm capacity. And of course, Massachusetts is one of the outliers. In fact, all of New England has far more dorm beds than hospital beds, way more than I realized when I started working on this. So this makes the matching problem fairly solvable. We've set up a website that I invite you to visit to play around with the model yourself, but I'll just take a very few minutes and walk you through how that works. So you can visit it yourself at mggg.org/COVID-19. COVID-flows, which is the URL that I've included here on the screen. Okay, let me briefly show you some of what you'll see if you go to that website. So we call it the Campus Coronavirus Response, and it's a web tool that's set up as a visualization counterpart to the underlying math model. So here's what the basic tool lets you do. It lets you look at the whole state or zoom in with a mapping tool on different parts of the state. So here I'm showing, of course, Boston, Cambridge. And then it lets you toggle the dorm capacity cap. So let me briefly explain, because this is one of the fundamentally useful aspects of the tool, I think. Of course, when you look at the normal operations of a college or university, it has a certain number of dorm beds. And as you just heard from Tony, the capacity to convert those beds to these COVID-related uses will be limited because you need to separate, you need to, all the factors that we discussed before. So the tool lets you toggle from 80% dorm capacity cap. So that's if 80% of beds would be available. That's probably unrealistically high, but you can toggle down to 60%, 40%, and the website lets you go down to 20%, and lets you see how the matchings would change. So what I'm showing you in these images is for instance, some of the major hospitals in Boston would send to Suffolk University if at 80% capacity, and then would start sending to larger campuses if the dorm capacity is lower. And to give you a sense, from thoroughly looking at Tufts plans for which dorm bed spaces will be used for what, I think 40 to 45% capacity is probably reasonable for many campuses, but that's of course an assessment to make locally. Another feature that we have that lets you interact with the model that I think you might find especially useful is data tables that show you, again, at those different dorm capacity caps, which are the colleges and universities, which are the campuses around the state that are close to maximum utilization. So as you toggle the capacity, you see which schools might be especially important in making this response. So how can you use this model as it exists now? And I'll tell you just a little bit about where we're planning to go with it in the coming weeks. You can use the tool, as I just indicated, to identify priority campuses. By sorting in order of utilization under different scenarios, it gives you a kind of priority order for mobilizing the campus response. You can also use the tool to infer what areas are that will be underserved. So even though here in Massachusetts, we have a very rich network of colleges and universities, by looking at the travel times, which you could see in the picture as the lengths of the lines that connected, by looking at the travel times, you can see where areas are that might start to strain their dorm capacity. And planners can look at these regions to try to decide where impromptu or other building types might be appropriate. And the last one is one that I think is especially useful, I hope, from the university point of view, is to figure out what the well-matched hospitals are in your vicinity. So if at a university, if you have a sense of what the capacity might be, you can use the tool to see what some natural hospitals are to match with. And of course, there are many factors that go into making good pairings logistically. So the ones that are closest in terms of travel time won't necessarily be the ones, of course, that you end up partnering with. But just as a place to start and understand which hospitals you're really well located to support, this tool can help you with that step. So that's the brief introduction to what we've put together just in the last 2 weeks. Where we're going with this is to stay involved in planning conversations and understand which hospitals and which universities should be removed from the model based on non-participation. For instance, we've already removed psychiatric hospitals from the model because their future in the crisis period is more uncertain. They won't have the same kinds of patient flows. And there are many other kinds of hospitals where there's a question mark about how they'll be used, rehabilitation hospitals and so on. And as we understand more about which campuses are going to mobilize in this way, we'll refine the model. We'll keep taking these updated model assumptions and design factors based on the facts on the ground in planning terms and try to keep this current so that it's a tool that, that really gets maximum use. I encourage you to reach out directly if you want to hear more about that tool. If you visit the website, we have a contact form and we'd love to hear from you. And with that, I will pass it on to questions and discussion.
Thank you, Moon. Martin, do you want to start with the first questions?
Well, I'm going to ask Barbara Stein, our Vice President for Operation, to read the first two questions and then provide an answer. Thank you.
Sure. Hello, everybody. The first question is, how are staff, dining hall, resident directors, IT, and such being considered in these decisions? How are they going to be communicated to? Have they been included in decision-making and logistics? And so I'll say, first of all those folks have been involved in the process from the beginning and very much part of the decision-making. So it sort of started from the ground up, and I'm remembering back to a few weeks ago, we had an initial kickoff meeting when we were sort of still all meeting in person to talk about this. And we sort of had a brain dump about, and there was IT, dining, facilities, public safety, everybody was there. And we sort of said what we thought we could provide, what we couldn't provide. And everyone left with the assignment to sort of write down and do an inventory of what they could and couldn't provide. And I would, if I could give one piece of advice on that, we did that sort of before we had talked to any of the community partners or hospital systems. So we know a lot more now. So I would say if you're doing that, maybe have one preliminary conversation with what the needs might be of who you might serve. And now what we've done is we've morphed into sort of an oversight group that sort of meets regularly and governs this process, but they've all been very much involved. And I'd say as we got into it, people went from being more nervous to being less nervous. Because what we've done is we've realized after talking to the community partners that they will do most of the services in the buildings, and our staff is not on the hook for being involved with people who might be sick or infected. So just the more you do, the more you learn, the more you know, the more the anxiety goes down and the more doable it seems. The second question is for the housing provided for medical persons. Whoops. And first responder non-patients. Who do you have providing housekeeping services in the buildings? Where are they staying? In the buildings where they are staying. It was mentioned that the medical facility partners would provide it in the places where the patients are housed. So the same goes for the medical professionals and first responders. All of the services are being provided by those entities. So
and just to add that when it's our staff, we're doing it, right?
It's our staff, we're doing it, right?
Yeah, there's not any of those. And for our students, we're doing it.
For our students,
for any city or partner, we're relying on them, and we will step up where they need us, but it's mostly their responsibility.
Right. And there have been a lot of discussions between the lawyers and working out the agreements, with the public safety staff. It's sort of our folks on the outside of the buildings and their folks on the inside of the buildings, and so on.
Great, thank you. Got a question here. Do you know or have access to how many hospital beds are currently occupied in Massachusetts? The Department of Public Health seems to keeping these numbers quiet. I probably we can't talk for the Department of Public Health. So that may be one of those issues. I'll throw this open to Moon, where you work with your local public health department. They might have a good handle on that.
Or Mike Apcon as well, or Dr. Sayah.
Yeah.
Mike, Assad, do you want to say?
Sure. So I don't know that there's an accurate count of how many patients are in hospital beds today in the Commonwealth. What we do know is that there are a number of hospitals that have become quite full over the last week, many that are stretching their ICU capacity, but across the Commonwealth, all told, when you look at all hospitals, there's still a fair amount of capacity left.
I totally agree. Usually under normal circumstances, most hospitals were running between 70 and 90% occupancy. These are on normal days. And I can tell you every single hospital has its own surge planning process, and every hospital has opened that handbook a couple of weeks ago and already working on stretching their usual staffed beds to the max. So if a hospital is running at 80% occupancy, they're already planning to run at 150% today before reaching outside the walls of the hospital. So a lot of the historical numbers, if you have them, are not holding true. You can easily and comfortably multiply that by 1.5 to 2 before we need to go outside the walls of the hospital, whether it is to field hospitals like what we're seeing or to solutions like these.
I'll just say, for the purposes of making the math model, we left as many numbers as possible as parameters so that we can update them as the situation unfolds. But for now, the model assumes that the flow from a hospital will be proportional to its number of beds. And we did that, of course, after talking with some of the folks on the call about what kind of assumptions are appropriate for different types of hospitals. While I'm talking, I'll take a few of the other questions I see in the Q&A that are related to the model and how it works. So one question asks if there's a way to get a similar model and data for other states. And another question asks, are we using national data sets, or is it only usable in the Boston area? So to take those together, we have a national data set provided by the Department of Homeland Security that gives us rough numbers on both hospitals and college university capacity across the country. So if you visit the website, you'll see New York and Michigan shown as examples using national level data sets. But for Massachusetts, we had access to state level data sets, and where we were able to compare the two, we got better accuracy with the state level data sets. So it's definitely not just the Boston area, it's all of Massachusetts, for which we had fairly high quality data. But of course, what that doesn't include is projections into the future of how much strain, and especially how much differential strain the virus progression is going to cause, because that depends on many factors, like where there are concentrations of elderly. In Massachusetts, for instance, the Cape Cod area has a considerably higher average age than most of the rest of the state. And that's likely to produce additional strain in that region. So we do have some plans to work with epidemiological modelers from the University of Washington to try to sync up their projection of virus demand with our network flows. And that's a plan for the next few weeks to try to incorporate.
Questions are starting to come a little quick. Let me catch up here. And maybe, Tony, this might be from you. Can you describe the partnership structure you have with the cities?
Yes, I mean, we're basically helping them with first responders. That's their biggest request. And we've come to an agreement. They're going to get access to, I think, 3 wood frame houses each. And as was described, they will be responsible for those houses and the individuals in them. We will provide support from the outside. And the idea, again, is to have 3 different units, one for healthy, one for exposed, quarantine, and the third for positive isolating.
And I could add to that, it's a license agreement that we've drawn up and they'll be using. But the cities have also been involved in knowing what we're doing related to housing other entities on campus too, because we are in those cities and it's important for them to know what we're doing. So we've kept them very much in the loop with what we're doing with Cambridge Health Alliance and others. Also, the way that we're having, the way that we track our own students in our residence halls, we need to know the health status of every student and where they are. It's a little looser with the cities. We're giving them a building and it's sort of up to them. We're not tracking who's in every room in the way that we would do our own students.
So that might be a good segue to the other question. Has there been any private sector involvement in our effort? If so, how?
Not that I know of. I mean, it's mostly nonprofit organizations.
Again, maybe for Tony or Barbara, can you describe any limitations placed on your students related to the non-student residential population?
I can't think of any limitations on our students. No, they're sort of on the other side of campus, eating on the other side of campus, and we have just enough students to be in one residence hall that's far away from where the community members will be housed.
I think we'd have to make sure that they're not walking into this area when these operations aren't going on, but that'll be part of our security efforts to cordon off the area and that people aren't just randomly walking through.
Right, part of the agreement with Cambridge Health Alliance related to housing patients is that there will be no visitors and the patients won't be walking around outside.
You know, it's not on here, but it might be a good segue. Can maybe talk about some of the communications we've done with the students on campus to explain what we're doing to kind of alleviate some of their fears?
Sure, we've sent out, we have obviously a Dean of Student Affairs office, which is more in touch with them on a personal basis and dealing with all their issues, but we certainly have had extensive communications to our students, their parents, our alumni, all our boards of advisors and trustees, as well as our internal community and our neighbors to discuss in detail what we're proposing here and ways in which they can ask questions and get answers. A frequently asked questions site as well.
One of the things that was helpful in this situation is we have had a historical, very close relationship as a healthcare organization with the university and with student health environment at the university. And we've been a partner for a long time regarding managing potentially students that could potentially be sick in the infirmary for the university and providing Arc resources, testing originally, and some support. So there was a natural partnership in here in evolving into this level of collaboration.
Great, thank you. Barbara, this might maybe a question for you. For colleges looking to follow Tufts of opening their dorms to members outside the community, what type of expenses should they expect to be responsible for?
You know, we have really been thinking about this because there's always a hidden cost, but we can't see a cost. We really have not been, all the repairs, any damage, any work that has to be done in the buildings will be done either by an outside contractor or by the occupant group. So, and we'll be reimbursed if we do have to do anything. So we really haven't seen any expenses to speak of.
So I guess that goes to the next question. Is there a tool/list that can be forwarded along the breakdown of all the criteria required to support housing these groups, i.e. close to roads, elevator access, bathroom access, other required amenities, or is this provided from the respective hospital local health department?
So we have developed sort of a few-page list of guidelines that I imagine we could provide of sort of things to think about related to all these things, and maybe Cambridge Health Alliance also could. So, and that would go for sort of any population. I think Cambridge Health Alliance probably has a more specific. I know they came and looked through our dorms to see about door widths and elevators and electrical outlet capacity, and the typical built-in 1960 double-loaded corridor dorm, which was recently renovated. The bathrooms are nicer and it has elevators, but that fits the bill. And it's we're not doing any retrofits for airflow or anything like that. It's sort of as is, furniture as is. So we can through Martin probably provide the sort of list of the process we went through and the criteria that we've been thinking about.
I'd also be happy to host that on the Matchings website, because I think some people who use the Matching site will expressly be interested in that information.
And it's currently up publicly and it's been pointed to, so people can get at the notes. But maybe Dr. Sayah or Mike Apgon want to say a few words about from their perspective.
I think, in these circumstances, we have to all think outside the box. When we started talking about this, if we're looking for ideal, you're not going to find ideal, because there's no way that you're going to have a duplication of all hospital resources in a building that's used as a dorm. But we all know that the main purpose of the hospital is also having a place for people to stay when they're sick. So if we start from this premise and build on it in a way to say, okay, we're not going to transform the dorm to a place to care for critical or acutely ill patients. It is a place to place patients that are healthy enough to be outside the hospital, but too sick to get home. And if we think about it in that way and early triaging those patients, and potentially when we get busier and busier, we may end up moving patients a little bit sicker in that direction. But at least for today, it is a transition to relieve the pressures on the inpatient units of the hospital and make sure that we continue to provide access while taking into consideration the demand and the staffing needs and the resources required in there.
Great, thank
Martin,
you.
may I jump in and add? Martin, may I add one piece to this, please?
Absolutely.
So this was a little bit overwhelming for us, I think, at the very beginning. And what we settled on was a much easier process that really slowed us down and made our life a lot easier. Was we at Tufts identified what resources are we willing to offer from the university, and we put those in one bucket. We already had our partners identified with Cambridge Health and Tufts Medical Center just from historical relationships we had with them. So what we did at that point is we reached out to them. We tried to generate what we thought their requirements were, which we were close but not totally correct. But we reached out to the hospitals and said, what are your requirements? And that made our lives a whole lot easier to answer a lot of these questions about what fits the bill and what doesn't. We presented them a bucket full of resources we were willing to give them or that we could give them. And they, with their requirements, were able to come through and select from that menu what worked and what didn't. So we were trying to put ourselves in their shoes when in reality we were a lot more restrictive than the hospitals were. They were happy to take a lot more than we thought they would. So what I would encourage you to do is figure out what resources you have to give and get with those partners as quickly as you can and let them tell you what their requirements are, rather than trying to figure that out for yourself.
Thanks, Wes. I would add to that, we are used to taking care of students. And what we have to remember with these populations is for the workers, first responders and healthcare workers, they're working 10, 12 hours a day. It's really just a place for them to sleep. And so it's not sort of the way we're used to thinking about folks in our dorms. And of course, for the patients, that's a whole specialty we should leave to the medical health professionals, which we're doing.
Great, thank you. Other question, organizations are already reporting difficulty in finding qualified staff for their additional sites. What is my campus's liability if outside staff are unqualified? Should we be checking licenses and other qualifications if they are working on our campus? That's probably two-phase, one for the non-medical and one for the medical.
What I might say is that in these unprecedented times, the licensing authorities for the states, Department of Public Health in the case of Massachusetts, are providing a pretty wide latitude for helping hospitals figuring out both the staffing and the facility aspects. And the responsibility really needs to be with the healthcare organization to figure out what's an acceptable facility and staffing model for the needs of the patients that we might relocate. As we do this, we're working closely with the states. It's no different than the way we're all going about standing up field hospitals at convention centers and in community centers and other things. And the hospitals have a robust approach. It's been modified significantly in these challenging times, but we have a robust approach for checking on licensure and qualifications and making the kind of staffing decisions and facility decisions that match the patient's needs with what can be stood up in the face of fairly unique circumstance.
And I agree. I can assure everybody that we take this very seriously. And at the end of the day, they are our patients, and we're not going to put a patient at risk or an organization at risk or a healthcare personnel at risk. Safety is number one. And that philosophy extends to every place that we see a patient, whether it is at the hospital or at the clinic or any new facility that we extend our care to. We are very vigilant about making sure that the staff that is caring for the patient is qualified, is trained, and trust me, we're doing a ton of additional training, because even for people that have been in healthcare for so many years, these are new times and these are challenging times, and there's a lot of additional training that they need to go through, whether how to don and doff personal protective equipment, how to approach patients, how do we cohort patients, how do we manage visitors, and we haven't had any visitors in our facility now for almost 4 weeks, and the same thing extend to that facility. The plan in here is to extend the same vigilance and requirements to that facility as we have in the hospital. This is not an afterthought. There's been a lot of work that we've done and a lot of thought in really planning this. And we take this absolutely very seriously, and we feel extremely fortunate to be able to develop this relationship with a willing and an amazing partner in Tufts University. And I think our patient population and community is fortunate to have that partnership in turn.
And I'll just add that the license agreement that we have in terms of our liability says that the outside healthcare provider will get all licenses and permits required for the use.
Great, thank you. Our next question is, have you had guidance from MEMA related to how they would want individuals spaced out within a residence hall to help reduce contact if you had space that was mostly horizontal flow? I can probably answer, I'll turn over the panel, but MEMA generally, when it comes to medical issues, defer to the Department of Public Health, our local health organizations to determine those type of questions. If it's a shelter with non-medical, they might provide guidance as well, but as a general proposition, they'll defer any medical questions to the Department of Public Health. So I'd open it up to our Barb or to the medical team. Make sense? Okay. Great, thank you. We had a couple questions here on the link to the legal webinar that was mentioned. We will get that, and just so you know, all these presentations, to include a recording, will be posted, and we'll make sure that link is on there as well. Our next question, have your faculty or staff had any concerns with Tufts providing these facilities for this type of use? Barbara, you want to go on?
Sure, the answer is yes. I don't think faculty so much, but our facilities staff were very worried about it at first, as well as the custodial staff, but that's gone down, that worry, since we've had our agreements that they really won't be entering or working in these buildings. Public safety is an exception. They are still concerned, and their union has said that they will want hazard pay as a result of this. So we're in the middle of those kinds of discussions. But that all seems surmountable. And in the end, everyone understands it's the right thing to do. So yes, there are concerns, but I don't think they're showstoppers. And having them involved from the beginning has been really helpful. Who's the next one? Who's paying for things like heat, air, internet, water? We are, and I think those are things we're not charging for to the partner. We will probably end up applying for fund reimbursement, at the end of the day for that, but we're paying for that.
And that's a great point as well from a reimbursement, especially as we look to FEMA through the Stafford Act. As I tell the team here at Tufts, save all your documentation, ensure you're matching it to work outside the normal scope of what you're doing. I know MEMA has a webinar weekly on this in terms of reimbursement. So I'd encourage you to form a team at your institutions and start tracking those costs. And having gone through the application process for reimbursement, it can be quite cumbersome. So thank you. Next question, prior to the arrival of the outside people being housed temporarily, are the physical spaces assessed with regard to their condition to be able to recoup repair costs later? Room conditions reports done before and after?
Yes, they were sort of prepared as if they were being prepared, you know, cleaned, and sort of we tried to get in as many of the regular repairs we would normally do during the summer into these buildings, so they're sort of in ready condition. And we've developed a special cost code, a COVID-19 cost code, and so we'll be tracking costs related to this. And it's in the agreement that if there's any damage done during the occupancy of an outside entity, they will reimburse us. So yes, we're tracking all of that.
And this is probably the million-dollar question here at Tufts and all colleges. Did Tufts assume it would have their buildings back under the control by August? So I guess I throw it out to, do we have a projected timeline when we think we're going to get them back? And
We have, so the agreements are for an initial 2 months or 1 month, depending on the case, and then a week to week after that by mutual agreement. And what we have said is that once we have a date by which students need to be back on campus, we need access to the dorms 6 weeks in advance of that, because we don't know what state they're going to be in. We don't know what kind of cleanup there's going to need to be. And then we need to get inspections and all the regular things you have to do for dorms. So we thought that was a good window.
Barb, does that include the time for the hospital to wind down, or is that really complete handover 6 weeks?
4 to 6 weeks complete handover. So, you know, part of it is we'll just have to see what kind of condition they're in and how long it might take and how long it would take the cities to come in and do their inspection. But we felt that was a good window.
Maybe the medical partners might want to comment from their point of view of how long it might take to wind down activities if they're given notice.
Yeah, I mean, we hopefully by then we are in the recovery phase of the situation, and we have internal capacity. And as that capacity exists, we're planning to utilize that space less and less. So probably by then there will be very little utilization of that space anyways. And having as much time as possible, and we can continue in communication on daily basis, is that we collaboratively will plan the exit strategy. And I agree, I think we should be completely out of there a minimum of 4 weeks before the first student occupy that space. I think that will give the university ample time and us ample time to make sure that that space is ready, because we're not going to walk away and wash our hands from, no pun intended, from this whole process. What we're going to do, this is a partnership, and we're committed to do the right thing across the board. And I think our relationship really so far proves that, and we'll continue to do this.
The only thing I might add is that to the extent that we're using the space for healthcare workers, that can really be stopped almost immediately when we need to. And we also will be much smarter about what the demand might be for post-acute convalescent space for patients. Even as early as another 4 or 5 weeks from now, we may have a much better sense of what the overall curve of the pandemic might look like and what the recovery phase might look like. And that would provide the state, MEMA, other partners, ourselves, to come up with a backup plan to the backup plan with ample time to address. So I'm quite confident that we will be able to be out in time if we even need the space that long.
The next question is a really good one. I can address that. It's what visual tools are you using to view your facilities? How are you tracking assets around the campus? Any real-time location services to help manage cleaning facilities, beds, or just manage space as the need arises? So we had to deal with this for our own folks earlier probably than most, because a few days before, students were all supposed to be gone we had a diagnosis on campus, and we had 50 quarantined students across 19 different dorms. And we had, of course, people trying to move out, and we had facilities and custodial, et cetera, staff trying to access the buildings, and they wanted to know sort of where the quarantine, and we also had a dining operation that had to deliver meals to the quarantined people, which was a whole new thing. So it took us a week or two to work this out and get it right. And it's an Excel spreadsheet that is updated. It was a couple times a day. Now it's once a day. And it says where every student is living on campus, what their health status is, how much longer they're going to be there, so that every kind of facilities and operations person kind of knew what state they were in. And so now we kind of got into a cadence of that, and not saying there were any mishaps, but now we're in a good place. And now we've added to that the staff that we have on campus, the staff who are typically regularly living there, who, you know, and the staff who are, we have a few of our own police force who are self-quarantined or just living on campus. So we will add to that the community partners, but not on a by room, by person basis, just on a by building basis. At the same time, we've inputted all of this into a GIS system that's linked to a map that you can access, and you can click on the building and see who's in there and what state they're in. I think it's a really cool tool. I'm not sure it's quite as useful as the Excel spreadsheet, but we're experimenting. This is allowing us to get more innovative and experiment with some of those.
I would just also add on that is the ArcGIS system that we have, mapping system, which gives us kind of an overview of buildings, who's in the building. It's kind of a pretty neat interactive map that shows us occupancy and the status of who's in there, whether they're a medical patient or just a student or a first responder. These are great tools, and I know our student affairs department does a great job of updating that, and within almost real time, which complements those other products.
Yep. Will Tufts take a pilot credit for its services?
I'll take that one. No, we won't. I mean, you know, the pilot, we're committed to our pilot payments to our cities. And I think what we're doing in this partnership is another great example of how we do help our cities in non-monetary ways. In particular, you know, many of these first responders are the ones that come to our campus to help our students when they're needing hospitalization or observation for other medical or even now more frequently mental health issues. And so this is not the time to be turning your back on the very same individuals that come on your campus to help your students when they're not well and take them to your local healthcare provider where those healthcare workers take care of them. It's time to help our first responders and those healthcare workers with our resources.
Thank you.
So the next question is, will Tufts ask the hospital and city partners to replace soft furnishings like beds and sofas? And the answer is probably no, unless they're damaged and not usable. But with the period of time of at least a month that people are out, you know, that's enough time for the virus to die. And we don't think if furniture or mattress is in good condition that we'd have to replace it.
We're also working with both hospitals and some of our computer scientist robotics individuals to use similar technology that's used in the hospitals, to use UV irradiation to go into rooms after they're done and be able to sterilize them after deep cleaning. I don't know if the hospital folks want to talk a bit about that, but it's certainly another tool we have in our toolbox to help make sure the rooms are really cleaned before we use them for our own residents.
Yeah, I mean, we currently utilize that technology, and we've been utilizing it for a while, and more so in the last few weeks for rapid turnover of rooms, particularly in the emergency department. So we do have a UV robot in each of the EDs, and every time we turn a room, we make sure that that room is sterilized before we move in the next patient. Not only the room is thermally cleaned, but also is sterilized with UV radiation. and we're hoping to implement the same technology at this on-site, at the site, and particularly in between patients, and particularly after after occupying the site, making sure that every single room as we're exiting is appropriately cleaned, brought back to its original condition, and sterilized.
And Barb, I'm going to throw this next question at you, but probably in a broad, the question is, if there's an emergency in the dorm, will campus police respond, or should the new residents dial 911? I think the broader question is, how are we synchronizing our security on campus with our communities as well? How are we coordinating that effort?
Right. So I guess there's for the patient areas, there's 3 entities, right? There's the hospital security staff, there's the Tufts security staff, and then there's the police and the municipality. And the for the patient areas, the way the deal is with Cambridge Health Alliance is that they'll have a couple of security people there on a daily basis, 24/7, and they'll take care of anything inside the buildings. And Assad, you can correct me if I'm missing anything here. And that Tufts University will take care of anything on the outside of the buildings. And typically Tufts University takes care of things on the campus, not Medford or Somerville. So that's how that's going to work. Does that make sense? But of course, you know, anyone's free to call 911. You know, or the Tufts equivalent to 911.
I agree that there's a level of expected collaboration in here, and definitely this is a friendly environment. And the more we collaborate at our level, the more our staff is expected to collaborate at all levels. But first and foremost, we want to make sure that the environment is safe and people feel confident and safe, both patients and first responders and staff. And if there is any situation that requires all hands on deck, and I don't expect that to happen, but then all hands will be on deck and 911 will be called and police will be involved.
Yeah, and this is the benefit of having those pre-existing collaborative relationships. The first responders from all these entities already all knew each other, and so it's really helpful. The next question, are you charging external partners for use of space beyond coverage of any damages sustained during use? And the answer is no, we're not charging. There's no rent or anything like that. What are the total number of beds you expect to be used across the different groups?
I can say a word about that, which is just that based on the initial breakdown that folks at Tufts made about the different kinds of dorm spaces and how they'd be used. So the normal capacity is something like 4,000 beds, and just a ballpark number, I mentioned before, 40 to 45%. So that puts you at about 1,600 beds available. There are a lot of variables there, such as whether people need to be isolated. So it depends on the kind of use, how many beds are available. We built our model on the assumption that early, at least for the first few weeks, it will be overwhelmingly medical personnel and first responders that are taking advantage of the ability to use these beds. And then as the crisis matures, as it were, we built the model on the assumption that you'd see a shift to more patients being displaced from the hospitals as the hospitals reach their capacity. You know, this ties into all kinds of predictive questions about how hospital use will evolve. So it's hard to be more precise than that. But from everything I understand and the folks that I've talked to at different levels of crisis response, definitely everyone's thinking that the medical personnel and first responders will be the big bulk of the takers for this opportunity in the initial weeks.
And you know, we are learning as we go. And remember, for the medical facility, it's going to be dependent on staffing. And we want to make sure that, and the staffing model definitely will be different than staffing the hospital. But when you're talking about this number of beds, it definitely is probably greater than we ever going to be able to staff and manage in such a short time. So what we're going to do is we're going to contain the operation into a size and a level that we can manage and staff appropriately. Because going back to this premise number one is safety and making sure that the care that we are providing is as reliable as the care that we provide at the hospital. And that requires a lot of logistics, from security to housekeeping to food to clinical care to electronic medical record to interfaces, follow-ups, you name it. That level of logistics is tremendous, particularly that you're already working at 150, 200% capacity within the hospital, and now you're adding another campus. But we have to do what we have to do.
We have not done any formal projections of what we think will be necessary, but what I can say is we're expecting that our surge capacity internally within the walls of the hospital will take us up to about a little bit over 500 beds. Because of the questions that a few questions ago about staffing, inadequate staffing, we don't think we could stand up more than about 100 beds or less in a remote facility and still staff that safely. So that's sort of the upper limit of what we might contemplate. And then if we look at the number of staff, we have already made opportunities available for staff to stay close by. And, there's some uptake, but not a lot of uptake. And I would expect that those numbers would be likely in the dozens, not hundreds.
Thank you. And Barb, I'll leave the last question for you. When will the first people move in?
That's really up to our partners. We are ready and waiting, but nobody's moved in yet. So we're hearing this week or next week. But I leave it up to our partners.
Yeah, the first step was basically finalizing the agreement, and this happened today. So although we've been talking for a bit, and there's been planning and pre-planning, et cetera, and we're ecstatic that we moved beyond this very important piece, because all the questions that were asked today were all appropriate, and obviously we've thought of just about every single one. And now we're moving on into the implementation phase, and I wouldn't be surprised if we have presence on campus before the weekend. So we'll see.
We're ready.
So can I ask a question of my clinical colleagues? Obviously, first responders and medical personnel is the largest request I think many of our audience out there are receiving, but we have a unique situation where we've partnered with Cambridge Health to set up a COVID positive recovering unit. How important is it for colleges and universities to at least identify where that might happen in case there's a local surge? You don't want to start working on that part of it with only a couple days notice. Now, it may never get activated, but I think it might be wise, and I'd like to hear from you for other people out there what they should do in that area, because it's probably the big question mark of what they've not yet been asked, but are wondering whether they should do it or not.
So much depends on how local authorities are thinking about creating surge capacity. We know that we will have a significant need for what we might call post-acute, for patients that are convalescing and not able to go home, but either need some level of nursing care or just can't go because there's high-risk individuals in the home or things like that. We also know that at the peak of the surge, there may be a need to take care of people early on in their care before they're convalescing, but where they require lower level than what we might provide in an typical acute care hospital. In Massachusetts, MEMA is doing quite a lot to build surge capacity at convention centers, at an Air Force base on Cape Cod. And so we're really looking at what will we need beyond that. But the lead time is significant. And so both from the standpoint of staffing and figuring out facilities and transportation and everything else. So, I would say that the spaces need to be identified a good 4 weeks before we expect to need them. And that's the approach that we've been taking in both working with MEMA as well as working with partners that would help sort that out.
Yeah, absolutely. In our experience, we
3 weeks.
started talking about this almost a month ago, maybe a little bit over. And, I think a lot of the conversations were extremely fast because it didn't take a lot of convincing for all of us to be on the same page. I think that's very important. And I would venture to say that, Tufts was not the only organization that we had conversation with, and we're still having conversations with. But it takes all the stars to be aligned to get to this stage. And the duration depends on how quickly those stars get aligned to get this partnership. And there are other organizations that we've been talking with even longer, and the stars have not completely aligned yet. So, I think 3 to 4 weeks is very optimistic, and it's required as a minimum when everybody's on the same page. There is a certain level of trust that's required in here. And, although all the questions that were asked were absolutely appropriate and important as a list to check off, but you're not going to be able you're not going to be able to account for every contingency. And, this environment and this situation, as it's unprecedented, it will be very helpful to start working with entities that already have relationships and they already have a level of trust to begin with. And sometimes the word goes a long way, and the history goes a long way to make sure that this happens. But if we're going to go through the same modality of preparing, we're talking months, and we don't have that kind of time.
Hey, Martin, I don't think there are any other questions. Maybe we should close.
Yes, sir. No, that's it for the questions. And actually, we went over our lot of time, but I think it was worth it.
Okay,
Sir,
well, I want to thank all our panelists and on the audience for joining us. And if you have additional questions, we're here to help. COVID-19@tufts.edu. We can help direct your questions to the right person.
Thank
Thank
you.
you.
Thank you. Thank you,
Good luck,
everybody.
everyone.
And thanks for all the support. Stay safe.
sure.
Thank you.